The subject of the current lecture is acute coronary syndrome. My name is Hany Awadallah. I am an assistant professor of cardiovascular medicine at Ain Shams University. By the end of this lecture, you should be able to 1. Understand the definition of acute coronary syndrome. 2. Explain the pathophysiology of acute coronary syndrome. 3. Describe the clinical assessment of patients with acute coronary syndrome. 4. Describe the immediate and early management of patients with acute coronary syndrome. 6. Appreciate the role of medical therapy and revascularization, whether it's percutaneous coronary intervention or coronary artery bypass surgery, in patients with acute coronary syndrome. Number 7, outline the early risk stratification and management schemes for treatment of a patient with acute coronary syndrome. Number 8, you should be able to apply acquired knowledge on a virtual case scenario or virtual case scenarios and clinical situations. Acute coronary syndrome, Part 1. Definition of acute coronary syndrome. Acute coronary syndrome is a term that encompasses both unstable angina and myocardial infarction. Unstable angina is characterized by new onset or rapidly worsening angina, what is called crescendo angina, angina on minimal exertion, or angina at rest in the absence of myocardial damage. In contrast, myocardial infarction occurs when symptoms occur at rest and there is evidence of myocardial necrosis as demonstrated by an elevation in cardiac enzymes, namely the cardiac troponin or the creatine kinase MB isoenzyme. Pathophysiology of acute coronary syndrome. An acute coronary syndrome may present as a new phenomenon or against a background of chronic stable angina. Professor Muhammad Ismail presented you with a detailed description of chronic stable angina. The culprit lesion is usually a complex ulcerated or fissured atheromatous plaque with adherent platelet-rich thrombus and local coronary artery spasm. This is a dynamic process whereby the degree of obstruction may either increase, leading to complete vessel occlusion with ensuing myocardial infarction, or regress due to the effect of platelet disaggregation and endogenous fibrinolysis. In acute myocardial infarction, occlusive thrombus is almost always present at the site of rupture or erosion of an atheromatous plaque. This slide points to the type of atheromatous plaque or the atheromatous lesion that occurs in patients with acute coronary syndromes. A type 5 fibroatheroma lesion has a lipid core, has a fibrotic layer over the lipid core, or multiple lipid cores and fibrotic layers. What happens in acute coronary syndromes is that this lipid core becomes exposed to the intravascular lumen, which invites platelet aggregation, activation of the clotting cascade, and thrombus formation, leading to complete or incomplete vessel occlusion. Clinical features of acute coronary syndrome. Pain is the cardinal symptom. Pain occurs in the same sites as stable anginal pain, but tends to be more severe and lasts longer. Breathlessness, collapse, and vomiting are common features. Breathlessness may be the only symptom, which means that dyspnea happens without chest pain, and this is more common in diabetics. And silent myocardial infarction, which is the occurrence of myocardial infarction without symptoms, tends to happen in older and diabetic patients. Syncope indicates profound hypotension and/or arrhythmia. Vomiting and sinus bradycardia are often due to vagal stimulation and are particularly common in patients with inferior myocardial infarction. Sudden death from ventricular fibrillation or asystole may occur immediately and often within the first hour. If the patient survives this most critical stage, the liability to dangerous arrhythmias remains but diminishes as each hour goes by. The development of cardiac failure reflects the extent of myocardial ischemia and is the major cause of death in those who survive the first few hours. End of part 1, Acute Coronary Syndrome. Thank you.